He is trained at PGI Chandigarh and has obtained his postdoctoral fellowship in critical care medicine from Sri Gangaram Hospital, New Delhi. I invite Dr. Deepak Saini. Thank you.
Good evening, everyone. I will be discussing about the monitoring issues in acute liver failure patients admitted in ICU. So it's a team approach, integrated approach, which can bring the best results for these sick patients. So in intensive care, we as intensivists should support the vital functions, should try to avoid development of complication, should be able to identify patients with bad prognosis, and should optimize conditions for liver regenerations and for those patients who are undergoing transplantation. So our approach should be to support the various organ system and to maintain the homeostasis. Now, one of the most dreaded complication in ALF patients is development of cerebral edema, and the earlier studies have shown that it has contributed majorly to the mortality. The cerebral edema leads to increase in ICP, which decreases cerebral perfusion pressure and leads to irreversible neurological injuries, which may cause patients death, or if patients recover, they may have deficit neurological functions. So the clinical signs are there, but they may not be present until late, or there can be various factors which can also bring out such similar presentation, so they cannot be relied upon. So we have to rely on what various techniques to monitor the cerebral functions, and one of the most common is that ICP monitoring. The role of ICP monitoring is also somewhat considered controversial. There are studies which have shown that those ALF patients who have been monitored with ICP monitor in situ and those without ICP in situ, they did not find any significant difference in mortality and in those patients. So there are certain reasons where we think which favors monitoring is that intracranial hypertension is erratic. It can develop rapidly with few clinical signs. If there is a monitor in situ, then it helps us in early detection and titration of therapy. We can push for transplant if such options are available, and it has some prognostic value also. If ICP is high and perfusion pressure is less, probably these patients become a poor candidate for transplantation. So we should consider ICP monitoring if patient has grade 3 to 4 encephalopathy and showing posturing, if patient is listed for transplant, and if the arterial ammonia is higher based on certain studies, we can also consider ICP monitoring in these patients. So there can be invasive techniques which are one of gold standard, the putting intraventricular drain and then monitoring the pressure, and then there are microtransducer based devices. We can see there are certain risks associated with them, most commonly the risk of bleeding and the risk of infection, and while the EVD is the gold standard, obviously it has the highest number of complications because we are right there in the ventricle in a patient who having cerebral edema. So squeezed up ventricle, we are putting up a catheter over there. So these transducers, they are also used. As you can see, as we go towards parenchyma from surface, the risk of bleeding increases, where the risk of infection is almost same. So the most commonly used is an epidural transducer. Among the non-invasive techniques, we have CT MRI, ophthalmoscopy, jugular oximetry, optic nerve sheath diameter by ultrasound, and transcranial Doppler. CT MRI, obviously, we can look at and see if we have a previous scan that these patients have developed cerebral edema. But what's the disadvantages is that the risk of patient transport, initial CT scan may be predictive, but subsequent scans not diagnostic of the ICP course. It is expensive, and you need to have a radiologist, and there can be a delay in getting expert report, so which can hamper your treatment. So we need to move beyond that. Again, ophthalmoscopy, optic disc edema is there. You can look at it, but it often develops late. And in certain ophthalmologic condition, there can be edema without a raised ICP. So again, there are certain definite flaws with this. Jugular oximetry, yes, we can use. We put a catheter in the jugular bulb, and then we monitor the various parameters. It actually is a marker of adequacy of global cerebral blood flow in relation to the metabolic demand. So there are certain normal values which have been calculated, and it helps us in assessment of cerebral oxygen use. Now look at this graph. In this, what we see is that patients, here the cerebral blood flow is 60 ml, here it is 30 ml. And if this is a constant, we see a fall in jugular venous saturation. So obviously, this will alert us that the patient's oxygen blood supply is getting compromised, or we should intervene. And the arteriojugular venous oxygen content also, the difference also increases. So it gives us a metabolic picture inside what's going inside the brain. So it can also be used in deciding the hyperventilation therapy. Suppose some of these patients have luxuriant perfusion of the brain, and the AgVO2 difference is on the lower side. So if we do a hyperventilation, this value will increase towards the normal range which I have just shown. And on the contrary, if the value is high, and say the 6 ml oxygen per 100 ml kind of thing is there, and if we are going for hyperventilation and we repeat and we find that the value has further increased, that means in this patient hyperventilation is not helpful. So definitely jugular venous saturation can help us in guiding in what patients should we go for hyperventilation, in what we should not go. And there is a correlation between ICP and jugular venous saturation. At values less than 60% and more than 80% has shown a good sensitivity and specificity. Coming to the optic nerve sheath diameter by ultrasound, this was initially used in trauma patient, brain trauma patients, but because it can be done at the point of care, it's fast, it can be repeated. So it has also now been used in ALF patients who have cerebral edema. And there is a good sensitivity specificity with monitoring this ONSD, and the cutoff point is 5 millimeters, and when this diameter increases beyond this, then we can be alert that this patient is showing signs of CNS deterioration. So various studies, mostly in trauma patients, has been done, but a very good correlation has been seen with this value of 5 millimeters and with good sensitivity and specificity. So as I already discussed, it can be done at the bedside, non-invasive, expensive, not much expertise, just some practice, and anybody can do this, and it can help you for guiding your monitoring and treatment. One of the study I would like to quote is that in this 22 patients, the pediatric patients were examined, out of which around 12 patients died. Of these 12 patients died, this was after transplant and these were before transplant. It was found that 5 patients in this group have raised ICT features and 3 in this. Here the graph you can see is correlates very well between the values of ICP and ONSD. And the mortality with when the absolute values were compared were clearly seen that the brain edema, there was a correlation between ONSD and ICP values. Now we can also use transcranial Doppler, which measures the cerebral blood flow velocity, and we can use the data from that to understand the cerebral hemodynamics. So obviously it's do not give us the direct picture, but the parameters which we can see, the kind of the velocity time graph, the waveform we get, can help us in assessing how the patient's brain is doing, and how should we act at that point. So the various arteries can be looked at, but most commonly the MCA is seen. And the common parameters which are seen are peak systolic velocity and diastolic velocity, and then there are certain derived parameters. And studies are there which have shown that there is a good correlation between these indexes. In acute liver failure also, there are certain studies which have shown that those parameters which have good correlation in trauma patients, neurotrauma patients, can also be used in liver failure patients with a good correlation. However, this study by Agarwal et al. Is an excellent study which gives a deep insight into how should we use a transcranial Doppler in management of ICP, and they did it. It was a retrospective study, but they did it quite well, and they reached certain parameters, and if those parameters are observed in an efficient way, then it can tell us that how the patient is performing. So what they did is that they defined certain points on the velocity time graph, and then they assessed at various ICP levels how it was. So they find that when the ICP was normal, this was a normal waveform, and as the ICP started increasing, like here there is no significant change, but there is an increase in velocity. You can see on the y-axis it has increased, and as the ICP goes on increasing, there is change in the waveform. You can see this thing is present in these two, but it has disappeared, and it is reflecting that the autoregulation is going out of control, and at the end it is just a passive kind of thing, which each systole there is blood and then it's going back. So what they say that the TCD waveform can be used to assess the cerebral dynamics of ICP and CPP and can help us in managing the patient. But obviously we need to have more studies that how more frequently we can use. The biggest advantage with this TCD is that you can do it at the bedside, and continuous monitoring you can do. So this is a comparison, and based on expertise we can use these modalities. And another most important system is cardiovascular system. The most difficult challenge as an intensivist is regarding the assessment of fluid status of the patients. This is, I think, the most difficult question when you stand in front of patient to decide whether what we should give fluid to this patient or not. So lot of things, as we all have grown up with looking at CVP, and new modalities have come now. So there are invasive methods and non-invasive methods, echocardiography, Doppler esophageal ultrasound. So there are advantages with both TEE and TTE, but TE is obviously probably some of the liver transplant centers also use, and it provides a good assessment of the overall heart picture. Or esophageal Doppler ultrasound has also shown a good correlation with respect to cardiac output. Whenever cardiac output has been measured, it has shown a good correlation with other techniques. However, I would like to discuss two important points. One is the static parameters like CVP and pulmonary artery occlusion pressures, and regarding the dynamic parameters, which are now most commonly used, which are pulse pressure variation, SVV, and systolic pressure variation. Now this article asks a very good question: does central venous pressure predicts fluid responsiveness? So we all have always look at certain CVP values and decided, okay, we should give fluid to this patient and this patient is overloaded. But just let us see what these people concluded. So they included around 803 patients with from 24 studies, and they found that around of these 803 patients, only 56 plus minus 16% responded to fluid challenge. So it's virtually like that you are standing near the patient and you're tossing a coin and say, okay, let's give the fluid and let's not give the fluid. So it's something like that. So their conclusion was that CVP should not be used to make clinical decisions regarding fluid management. And then coming to the newer dynamic parameters, this review article discussed that these dynamic changes in arterial waveform derived variables have a very good correlation and for assessing the fluid responsiveness of the patient. And they studied around 685 patients in 29 studies, and they found that they have an excellent correlation. So and this is relatively simple to assess with the monitors, kind of monitors now we have in available to us. It's not difficult for even a person to understand with these parameters whether you want to give. For example, like this patient, see we all can see that the variation is there. So this was before fluid loading, and after the fluid was given to this patient, we see that that variation has reduced. So this is a very good parameters, and you will if you are using, then obviously you all must have seen that these changes do occur. But these are usually used in mechanically ventilated patients, and they should have a normal sinus rhythm. So there are certain restrictions to with these parameters, mechanical ventilation wise, we have to see what are your ventilator settings before jumping on that. Okay, let's give fluid or not, should not give fluid. So CVP monitoring is question mark, and now these parameters obviously are more preferred one. Oh, sorry. So in coming to the respiratory system, most of these ALF patients having higher grade of encephalopathy are intubated and ventilated, and we should look at the end-tidal CO2, various loops and curves deciding, and the pressures, plateau and peak pressures, to tell us how the lungs are behaving, how our fluid therapy is behaving, and obviously we should have a view about the PEEP. So PEEP is considered quite dreaded when we think about ICP and cerebral edema, but let's look at this study. This study though was done in animals and then with some neurological patients having subarachnoid hemorrhage, but they found that even with a PEEP up to 15 centimeter of water, there was no significant change in the ICPs. There was no significant change in the regional cerebral blood flow and the tissue utilization of oxygen. And the similar changes were seen in the patients at various days. They observed from day 1 to day 7, and all these parameters, cerebral blood flow, mean arterial pressure, and ICP, did not change significantly in the PEEP range from 5 to 15. So what they concluded is that PEEP per se directly does not have an impact on regional cerebral blood flow, but we should be sure that we are able to maintain the mean arterial pressure. So we should use the minimum possible PEEP, and we should maintain the MAP, and probably the CNS issues will not be there related to PEEP. And we always, whenever we try to increase the PaCO2, we have in the jest of in decreasing the PaCO2, we increase the respiratory rate of the patient. But we should always keep in mind that we should give adequate expiratory time on the ventilator. If we do not allow that, then auto PEEP will occur, and that will again decrease the MAP. So this is very important. If you are increasing respiratory rate, look at the flow time graph and see that there is no auto PEEP. So, and these are the usual: prevent hypoxemia and maintain eucapnia or slight hypocapnia. Renal system, there are no systematically studied studies which has any information in ALF patients with renal failure, but there is a hypothesis that vasodilation is generalized and not restricted to splenectomic areas in cirrhosis, and there is a profound neurohormonal system activation which then subsequently lead to vasoconstriction in regional vascular beds. So, what we are doing is actually dividing the patients based on the rifle criteria, and we are monitoring these parameters to reach a conclusion whether the renal injury is pre-renal or it's a functional failure or there is ATN. These are ALF grade 3-4 patients are usually agitated patients, and the agitation can increase ICP. So they need to have adequate sedation and analgesia, and when ventilated we always use neuromuscular paralysis. So if we are ventilating such patient, we should ensure that patient are adequately paralyzed, and nerve stimulation should be used to assess adequacy of muscle paralysis.
Dr. Deepak, we'll have to just hurry up with the last
slides.
Yeah.
I'm just finishing off. And temperature monitoring is important for especially in preventing hypothermia, and we can think about hypothermia in osmotherapy refractory intracranial hypertension. Jalan has done a lot of study, and probably we know about this. Especially is useful when we are targeting transplant in such patients. Infection monitoring, surveillance is done by chest radiograph and the daily bacterial cultures. I don't have data of use of serum procalcitonin used in ALF patients, but at the moment we are doing it. Probably by year end we will be able to publish that data. And a word about coagulation. INR is just one side of the picture. We should always look at the anticoagulation factors, and a global picture of coagulation should be seen. Probably TAG is a good monitoring tool for looking at the coagulogram in these patients. And we should avoid hypoglycemia and maintain a moderate glucose levels. And these studies are there to support this moderate glucose level. Thank you.
Thank you, Deepak, for very informative and nice talk. Sorry, because of time constraints and yet many more talks to follow, we'll permit 2 questions. And if anybody is. Please.
Take-home message for intracranial monitoring in acute liver failure? There are groups who do it, groups who don't do it, and we certainly haven't done it forever.
So
'Cause
we
you
are,
gave us very nice talk overview, but what's the message
my
for us?
my own assessment is that probably ONS3 diameter is one good thing that we can do without hassle. Transcranial Doppler require a lot of training to reach to find the windows and look at those things. Probably ONS3 is one thing that we can do, and if we can, and one thing is that if we can give mild hypothermia, if not even moderate, probably we can give time patient to for recovering. These 2 things I think I will recommend for ICP monitoring.
If there are no further questions, I'd like to thank Dr. Deepak